So the focus of this entire course is going to be clinical practice, clinical practice, clinical practice. We are not going to get into molecular, genetic, mutation related stuff. It is going to be nothing but practice oriented. So this one is more like a taste of an introductory talk for this course. So all of us, and we are all aware that today's clinical practice is very heavily dependent on testing, on diagnostics, whether it is blood test or radiology, uh, pathology, biopsies. Gone are the days where we will base our diagnosis and give treatment and follow purely on clinical examination, signs, symptoms, right? And amongst all the tests that we do, a CBC is one of the most commonest tests ordered by anyone around the world. And certainly in community practice, this certainly is the commonest test that we prescribe. It's available everywhere. You can go to any corner of the world today, practically. And I've traveled extensively in Southeast Asia and Africa. Complete blood count is available. Automated complete blood count is also available. Everybody has some kind of a cell counter, and if not in their town, in a neighboring town, it's always there. Having said that, what we are never confident about is whether the reports are reliable or not, especially in our part of the world where regulation is an issue. So, for example, NABL or NABH or any other such, accreditation agency, which try to ensure that the quality of testing is proper, the quality of treatment is proper, are not mandatory. They are, people can choose to get accredited or they may choose not to get accredited, as opposed to centers in a developed country where if you are not going through quality accreditation, you cannot run a lab. So that is the key, and that is where quite often we are confused as to in this lab I had a platelet count which was 1.5 lakhs, in another lab it was 1.75. What actually is happening? What's happening? What's the diagnosis? Do I need to do any further tests? When should I repeat my testing, etc.? So let's start with that. Let's start with how do we ensure that the reports that we get are accurate. And what I'm going to tell you is not restricted just to a CBC or any cell counter. These are general principles of laboratory testing. The errors in a lab are divided into pre-analytical. That means before the blood sample is put into the machine. So pre-analytical, then analytical, and finally post-analytical. In pre-analytical, what could actually go wrong even before we collect the blood sample, right? What are the things that we need to be aware of? We need to be aware of is the patient healthy? And we will come to a small brief discussion on how what seems to be routine can profoundly affect the blood reports, right? Hydrated, sick, toxic patient, dehydrated, stable, not stable, all of that we have to see. The blood reports also change based on how active the individual is. Sometimes what happens is if you've been working continuously from morning till evening and you give a sample in the evening, especially after excessive physical work, the reports may be a bit different compared to how they would be early in the morning without any major physical activity preceding the sample collection. What kind of a food and which medicines is the patient on? A classic example is bleeding. Whenever we get a patient with excessive or unusual bleeding, one of the first things that a hematologist asks for is, hey, which medicines are you on? You know, and when we do platelet function tests, it's interesting that cough medicine, antihistaminics, can affect the report, right? Dietary wise, you all know this, right? Nutrition, iron deficiency, B12, non-vegetarian diet, all of that can change and affect. One excellent example is if your patient is on anticoagulant drugs. So let's say vitamin K antagonist, typically warfarin or acetone, and you do a PT-INR today, right, as a baseline, and somebody has been on, say, warfarin for the last 6 months, and today if the patient has a heavy non-vegetarian meal with chicken liver or mutton liver, that gives a boost of vitamin K, and the PT-INR will be lower tomorrow, right? So these are all of the issues that we have to be aware of if we are getting some kind of a problem. Yeah. Um, However, the important thing is usually this does not affect the bone marrow. And the most important takeaway message from this slide is if you have a patient with anemia and say a hemoglobin of 5 grams, right? And you want to send iron, B12, or folate levels, take a sample, pre-transfusion sample, and give off the transfusion. Don't hold the transfusion. Yeah, transfusion is a clinical decision. It's a life-threatening condition is there. If the hemoglobin is very low, please go ahead and give the transfusion. But ask your team, your residents, to collect a blood sample before transfusion or before giving vitamin B12 or iron. Sometimes what happens is the patient comes to you and has already received transfusion outside in some other hospital. Then what do you do? Then how are you going to check the iron, B12, folate level? What we try to do is if the patient has gone to another hospital recently, we call them and we check them. Do you have a pre-transfusion sample remaining in your fridge in the lab? Quite often they have, and then we take that and we send it for testing, right? So these are some of the things that we keep in mind pre-collection. What about during collection? Usually we take blood sample from a vein, right, with a needle or a vacutainer system, syringe needle and vacutainer system most typically. And when this is done, a tourniquet is applied. Now, in major cities, there are phlebotomists who are trained in proper tourniquet, blood sampling, etc. But otherwise, they may not be trained, right? A lot of majority of the phlebotomists, whoever collect the sample, they are not trained. So they need to know how to apply the tourniquet. The fact that they should release the tourniquet as soon as the blood begins to flow in the vacutainer or in the syringe, because that avoids hemoconcentration. It can change your hematocrit. If you're collecting sample from an IV cannula, there may have been some injections, it may have heparin, it may have normal saline. So it's important to discard the blood and first flush the cannula with normal saline. And even after that, discard the first 5 ml. Don't send the first 5 ml for testing if you're taking sample from an IV cannula. Quite often in neonatal ICUs, pediatric ICUs, capillary sampling is done from the heel, from the sole of the child. We need to remember that if you're doing capillary sampling, you should not squeeze the sole of the infant too much, because it will change the hemoglobin, it will change the WBC and platelet count also a little bit. However, if once the prick is done, the whoever is collecting the sample from the heel of the infant, they should wait for a free flow and only then take, because then that is fine. Then you're going to get good values. Similarly, when a syringe is being used, they should not try to suck out too much, because then the blood agitates in the syringe, and the RBCs can break, leading to hemolysis. At the same time, drawing blood too slowly and putting it in the tube and not mixing the tube properly will mean that there may be small clots in the blood. So you are not going to get a proper platelet count. Yeah, all of these things are there. And quite often the type of tube, every tube has a specific purpose. So EDTA, citrate, etc. Whoever is using, there are very good posters available online, and we should print these and keep them on the wall so that everybody knows which tube to use for which test, how much blood is to be collected in the tube, etc. Once we've collected the blood, you have to label the tube. You have to ensure that the form is correct. Most of the mistakes in laboratory tests are pre-analytic. Wrong tube, not labeled properly, blood not collected properly, etc. Yeah. So ensure that that doesn't happen. Whoever is taking the sample is supposed to ask the patient, "What's your name?" Look at the form, ensure the name is right, put the correct name on the tube, etc., etc. Ensure that we are using the right amount of anticoagulant. So if you are using a vacutainer, you don't have to worry. It will only take in as much blood as required, with the vacuum that it has. But if we are collecting in a syringe needle and pushing blood into the tube, then we should not be putting in too much blood. And, because if there's too much blood compared to the anticoagulant, some of the blood is going to clot. Now, there is something very interesting that we in hematology see pretty frequently. We've all seen patients with high hemoglobin, 17, 18, 20, 21 also. And what actually that means is if you look at the so if you take somebody's blood, right? Now, this is an example of normal blood. You take whole blood and you centrifuge it. We've all learned in first MBBS, when you centrifuge blood, the cells, the heavy cells will sink to the bottom of the tube. And the lighter plasma stays on top. Yeah. Now, this is what we normally see in a hemoglobin of, 11 to 15 or 16, 11 to 14. Yeah. And based on the normal amount of plasma, the tube has certain amount of anticoagulant. Okay. The tube has certain amount of anticoagulant. Now, what happens in polycythemia, for example, there are too many RBCs. There are too many RBCs, and there's very little plasma. Now, if I take a polycythemia patient's blood, put it in a sodium citrate tube, yeah, there is very little plasma. It will absorb some of the anticoagulant, sodium citrate, but a lot of sodium citrate will be left back. And now, if I send this for, say, a prothrombin time, a PTA, PTT, you have too much anticoagulant already remaining, and you're going to get a false high PTA, PTT, right? So when there is any extreme, very high WBC counts, very high hemoglobin, then your lab should be aware, hey, maybe I have to use a different tube, or I have to change the anticoagulant ratio. Yeah. Once the sample is collected, it has to be stored properly. Quite often in community labs, we see the sample is just kept on a desk, and India being a hot country, it degenerates. How long can you keep sample? If you keep it in a routine refrigerator, which has about 4 degrees Celsius, you can keep blood for up to 24 hours. And that's fine for a CBC test, even after 1 day, right? And there are some tests such as cold agglutinins, and we'll come to this in the anemia, hemolytic anemia class, where you have to collect sample and store it at body temperature. So if we are suspecting cold agglutinins, all right, we take a water bath, heat the water at 37 degrees, keep the syringe and needle at 37 degrees. So we pre-warm the syringe and needle. We pre-warm the vacutainer at 37 degrees. So when we actually take the syringe and needle, which is pre-warmed at 37, and we take the blood. Otherwise, if I take a standard syringe and needle, as soon as the patient's blood flows into that syringe, it will agglutinate, right? But it does not agglutinate in the body. The body is at 37 degrees. So there are certain key things that we look at for rarer tests, but otherwise, you can take blood at room temperature and keep it. But if you want to keep it for further testing, it has to be kept in a standard fridge. If it has to go to another lab outside your city, then it should be sent as quickly as possible, and again at the right temperature. It should not heat up during transit. Now, all of these are, pre-analytical issues, and You won't believe how much this can affect. We do something called as karyotype chromosomal analysis for cancers. And if you look at published data, once you take a sample and send it for karyotype chromosomal analysis, it's a kind of a genomic test. 90% of the time you should get a report. But if you look at publications from India, Africa, Bangladesh, you will see that because we are hotter and warmer countries, 40% of the times, 40 out of 100, the sample degenerates, and the lab will not be able to do a test. So all of those are pre-analytical. Let's look at analytical, what could go wrong. Again, when you are analyzing, you have to rewarm the blood. You take out the tube from the fridge, you have to rewarm it to room temperature, that is 21 degrees, before you test. Otherwise, it's very thick. You are not going to get a proper report. Before putting it in the machine, it has to be mixed properly, because some of the RBCs may have settled down. Some of the platelets may have aggregated inside, right? So there is something called as a mixer, a rotating mixer, which any decent lab should be having it. If you don't have a mixer, you have to, whoever is testing the blood has to invert the tube 8 to 10 times by hand before putting the blood in your cell counter, the machine which is going to record. And this is the most contentious part. Wherever you are sending your sample, yeah, please check if the lab has any kind of quality control. And most of the labs, the pathologists or the laboratory technologists who own it and they run it, they will say, yeah, of course. Yeah. Last year only we did our quality check, or once in 6 months, or they will do a quality check before accreditation, before inspection. No, the lab is supposed to run quality control every day, every day. And busy labs, if it's a tertiary care hospital and the lab is doing 300 400 CBCs, they have to run quality control in every shift. That means 8 hours, 3 times in a day, every 8 hours. So truly good quality control is important. But we can't control this all the time. We can't dictate what to do. But if you start asking this, then the labs start feeling the pressure of doing some kind of quality management, of doing some kind of accreditation, NABL, or whatever it is, something better than nothing. And if you're not sure, then when you think, no, I'll send a sample to some other lab, find out if you can send it to an NABL accredited lab. There's no point in sending repeat sample to another lab which does not do quality control, right? So there are districts and villages where there is not a single NABL lab. What to do? This is the real world. But then rather than just repeating in different places, ensure that you do it, your second test or whatever goes in an accredited lab if possible. Post-analytical, what are the errors? Obviously, wrong report, printing error, typing error, or somebody is looking at the screen and writing the report by hand. All of these can lead to errors. Now, assuming that our lab is doing a good job and errors are taken care of, what are the normal values? We need to understand the meaning of this word normal. This is very, very, very important. How do we establish a normal range? It may be hemoglobin, it may be creatinine, it may be height. What is normal height? Yeah, if we compare our height with say particular European population, we will turn out to be too small, short in height, correct? Then there are other African or South American populations which are pygmies. So where are they? What is their normal height? So the normal range has to be established as per the population. We have to test 50, 100, 200, 500 people, and we have to plot the curve. And we then have to say that, okay, I am going to say 95%. So whatever is the range in 95% people, which is median plus minus 2 standard deviation, that's going to be my normal range, right? So we have to be clear how is the lab telling something is normal or abnormal. It's also important that every machine and every reagent will give a slightly different normal range, correct? So again, we have to be aware of these things. The ranges are different as per gender, as per genetic background, and we'll come to a classical case of this in our, platelet lecture. What happens is in East India, okay, East and Northeast India, the normal platelets, okay, in about 25% of the population of East India, they are larger than normal. Platelets are larger than normal. About 25% of people in East India, West Bengal, Assam, etc. Now, what happens is one giant platelet is equal to 2, 3 normal platelet. So their platelet count, the normal platelet count may be 1 lakh, not 1.5, because their body does not need 1.5 lakh. They have giant platelet, right? And this is due to a particular mutation in myosin heavy chain, gene, but it does not cause any problems. It does not cause any bleeding. It just gives a false low platelet count. And many times these individuals will go from one doctor to another and they will be evaluated for ITP, saying, no, no, your platelets are only 70,000. But that 70,000 may be normal for that individual. We have to ask, anybody in your family has low platelet? They say, yeah, 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 my uncle also has. Then you start thinking, maybe there's a genetic background. Maybe this platelet count is normal for this family, right? Posture. You wouldn't believe this, and we've actually done this when I was doing my DM in CMC Vellore. Somebody is walking and suddenly they lie down. The hemoglobin can decrease up to 10%, right? High altitude. We've all traveled to mountains. Most of us have gone to Himalayas, and we see the people there are pink, right? They have high hemoglobin. At that altitude, a hemoglobin of 16 is normal, correct? And what about sports? There is this last 10 years, we have seen a lot of people taking up sports as a career. And there is something called as sports anemia. Sportsmen, professional sportsmen especially, their normal hemoglobin is slightly low. Of course, some of them, they abuse and misuse drugs. They may take erythropoietin injections, steroids, right? Bodybuilding, sports, all athletes may take it, and then the hemoglobin falls high. And in them, I'm not going to evaluate for polycythemia. I'm first going to ask, boss, do you take erythropoietin injections? Yeah, because they take injections and there is a massive turnover creation of hemoglobin. Their iron and ferritin levels are low. So these are certain nuances that we look for, and ultimately, we also have to understand that our values change with age. In children, especially newborns, the hemoglobin is much higher, and any pediatrician will tell you that, well, this newborn child hemoglobin is 12. That means she is anemic, and you would think, no, 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 12 is normal. No, but for that age, it is definitely low. Not only that, fetal RBCs are larger. The MCV, mean cell volume, is higher. Yeah, they have more lymphocytes and less neutrophils. So quite often, we get consults where they say, in this child, lymphocyte percentage is 65. Yeah, maybe that's normal for his age, correct? It's only later that the neutrophils become predominant in life. What about some individuals? Not genetic, not family, nothing else. How do we look at that? Whenever we get any patient, I spend a lot of time, the first 10-15 minutes going just telling them, do you have any report? What else do you have? Do you have printouts? Do you have any file? Give me everything. Do you have pictures in your phone? Show me everything. And then I plot it. I say, okay, this date hemoglobin was this much, WBC platelet, next day this happened, then transfusion was given. Without looking at the previous report, we can never say what's happening. And I'll tell you one phenomenal example, one patient that I saw day before yesterday. Now, this patient was referred to us for high platelet count. Okay, platelet count of about 8.5, 9 lakhs. And the physician said, hey, do you want to evaluate for essential thrombocytosis, right? High platelet count. And I said, yeah, why not? Why don't you send? And when I looked at all the reports, it turned out that 2 weeks before the patient had had a surgery. Yeah. And fortunately for us, there was a pre-operative CBC which was normal. Now, a major disease like ET, essential thrombocytosis, cannot happen in 2 weeks. Then what happened? There's a normal, then there's a surgery, and surgery is a stress. There may have been some infection. Yeah. Now, platelets are acute phase reactant. Do you know what are acute phase reactants? So, ESR, CRP, ferritin, these are all acute phase reactants. Fibrinogen, whenever there is an infection, inflammation, stress, these will go up. Similarly, platelets are also acute phase reactants. So any fever, infection, inflammation, the platelets go up. Even with iron deficiency, platelet count goes up. Now that's reactive. So in this patient, I said, hey, look, 2 weeks ago it was normal. Surgery is a stressor. This is reactive thrombocytosis. This is his body making more platelets so that the surgical scar will heal faster. This is nature's way of dealing with the stress. Don't do anything. Repeat CBC after 1 month. And if it's going to be normal. So it's very important to spend time doing this. Same thing, hemoglobin. Somebody comes with an HB of 11, but if a few days ago it was 13 and now it has suddenly dropped, a lady who's had massive menorrhagia, HB can drop by 1 or 2 grams and she may feel very weak or faint because that 2 gram drop, body has not yet adjusted. So it's also important to look at the trend. Now that we have gone through these core concepts, we're just going to briefly go through, some basic hematologic techniques. And first of all, I would like to say that we've all seen manual techniques, especially manual platelet count, and there is a machine platelet count, and we don't know what to trust, what to follow. Trust me, manual techniques are fantastic. They are low cost. It takes more time. However, very few people are trained to do it properly. Very few people know how to count platelets properly on a smear, right? Training is not great. And the automated techniques today, yes, they're more expensive. Putting in a cell counter, it takes money, but the reports are faster. You don't need too many people. Maybe one technician can run a whole lab, a small lab. You hardly need any people. But there is no doubt that automated techniques are more accurate. There's absolutely no doubt. If somebody says, the machine platelet count is 24,000, but manual is 40,000. So, no, 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 look at the machine. Yeah, the machine counts lakhs of platelets before it gives you a number. The machine counts thousands of WBCs and lakhs of RBCs before it gives you HB, MCB, etc. It's far more accurate, far more precise. Of course, again, the problem is if the lab is not doing quality control, then you can't trust the machine. But assuming that the lab is doing proper quality control, trust the equipment. Most of the standard cell counters are good. They have amazing technology. They use lasers, electrical conductivity. They measure the size of the cell. They measure whether they're granules or not. And after all of this, they give us this fantastic three-dimensional plotting of different kinds of cells and far, far accurate, right? Provided there is quality control, calibration, correct reagents are used, etc. Often we decide, okay, the instrument is showing something. I want a pathologist to actually look at the cells under the microscope. I want the pathologist to do a peripheral blood smear. Yes, fantastic. But is the pathologist and technician smearing properly? Are they using the right technique? And we are starting another course actually for pathologists for this. In March, we are starting. So are they smearing it properly? For example, these are the different kinds of smears, and A is on the extreme left. That's the only good smear. All of these, you're not going to get a proper reporting done. Yeah. And you can see this is from the same patient. If the smearing is not good, if it is too thick, there's too much blood on the slide, and then you will feel that there are too many WBs. Can everyone please mute? Okay. So if it's too thick, you might feel that there are too many WBCs and give a wrong report. If it is too thin, you may feel that you don't have enough WBCs. So smearing has to be done properly. Staining has to be done properly. You see, standard stain is what is called as Romanowski technique. And there are 4 types of Romanowski stains which are commonly used. Jimsa, Leishman, Wright, Jenner, all of them are fine, provided they are using the right reagents, the right dilution, blah blah blah, and all of those have to be standardized by the lab. And this is why you will end up getting very vague reports from different labs. These Romanowski stains have 2 components. Okay, they have 2 kinds of chemicals. There's something called as Azure B, and there is something called as eosinophil. It's phenomenal. It's brilliant. Azure B, when you stain the smear, the Azure B chemical will go and bind to acidic substances. Yeah, acidic substances, and it will make them look bluish and purplish. So nucleic acid, DNA, RNA, proteins, right? It binds to that, and then that looks purple. That's Azure B. Then there is eosin Y, which will bind to an alkaline substance, basic substance, which is hemoglobin. You see, you get this reddish orange because of eosin Y binding to hemoglobin in the RBCs, binding to eosinophil granules. Now, this contrast between this orange and purple helps us understand how is the cell. Is it a healthy cell? Yeah. Now, let's see what we mean by a healthy and unhealthy cell. RBCs. I am sure this is the most commonest uh, diagnosis in our clinical practice: iron deficiency anemia, right? Somebody comes to you with low hemoglobin, and you see that the report is hypochromic. Hypochromic means there is less color. There is less color in the RBC. Microcytic means it's a smaller RBC. Yeah. And rule of thumb for me, MCV less than 80, microcytic. Okay. So somebody has come with low hemoglobin, the cells are smaller and they have less color. Color means hemoglobin, right? So what is the cause? Of course, commonest cause will be iron deficiency. Now let me show you something fantastic, right? If we take iron deficiency patient's blood and we do a peripheral smear, we look under the microscope, right? That's a normal lymphocyte. All of these are RBCs. All of these are RBCs. Yeah. You see, they have different shapes, they have different sizes. And if you say this is a normal RBC, yeah, you see, this is smaller and it has less color because it has less hemoglobin. Yeah. If you look at this under electron microscope, this is how it looks. It's fascinating. Different sizes, and you see very less hemoglobin in this. Yeah, if you say that this one has good hemoglobin, yeah, good color, this has very little hemoglobin, so the central pallor is much bigger, right? Now, what our cell counter does, is it will measure the size of these RBCs. It will measure the size and it will plot that size, okay, on a graph, and I'll come to that. Now let us look at another disease where RBCs are smaller and they have less hemoglobin. That is thalassemia. This is a congenital problem. This child is born with a defect in the globin chain gene, right? That is why less hemoglobin is made. And again, the same, less color, smaller RBCs, less MCV. How do we differentiate iron deficiency from thalassemia? right? There is a difference. If you see in thalassemia, there is a genetic problem. Every RBC made in this patient's marrow, every single RBC made in this patient's marrow is going to be small, is going to be equally small, equally small. Yeah. You see, most of the cells have the same size. But you look at iron deficiency, some cells are very small, some cells are big. You know why? Because iron deficiency happens slowly. Iron deficiency happens over years. Iron deficiency is like poverty. It's like poverty. Suppose my salary stopped today. Suppose my salary stopped today. Okay. 3 months later, I will not have money in my pocket, but I may still have money in my fixed deposit. 1 year later, fixed deposit is also empty, but maybe I have some property. Okay. Similarly, what happens in iron deficiency? When iron is made in different parts of the body, different bones, some bone may have some iron left. Some bone may have some iron left. It does not get depleted everywhere equally. And RBC formed in that part of the marrow may have a normal size. But there may be another bone, another part, another marrow area where there is no iron left. And the RBC which is manufactured there will be very tiny. Hence, in iron deficiency, the size of the cells is different. Whereas in thalassemia, all cells are uniformly small. Yeah. And what the instrument does, I think somebody has, marked something on the slide. That's why you can't see this, unfortunately. So if you can see this curve, what the machine will do is it will measure the size of the RBCs. You see the MCV, the volume, mean corpuscular volume, and it will plot it. All right, it will plot it. Now you look at this curve, it looks wide. Uh, Ambuj, who is Ambuj? Ambuj, you are drawing on the screen, and that is why we can't see the screen properly. Can you please erase the red markings that have been made, Ambuj? Okay, I hope. Yeah, thank you so much. So you see, the RBCs, some are small, some are large, some RBCs are small, some are very large. You see, this is a very wide curve. On the other hand, if you look at thalassemia, most of the cells are the same size. This is a normal sized curve. It's narrow. This is called as the RDW, red cell distribution width. How is the curve? The machine gives this measurement, RDW. If your RDW, MCV is low, but if your RDW is more than 17, then you have small cells and you have big cells. And pathologists call this anisocytosis. Small cells and you have big cells. But if your RDW is normal, less than 17, then most of the cells are of the same size. They may have less hemoglobin, they may be smaller, but you don't have different sizes, right? In thalassemia, it's a genetic problem. That's one. Of course, for confirmation of the diagnosis, you're going to do ferritin for iron deficiency. Remember, ferritin is enough. You don't have to do serum iron and TIBC and all that. Ferritin less than 15, the only diagnosis is iron deficiency, right? And of course, again, there are rarer syndromes, aferritinemia and all that. But for all practical purposes, ferritin less than 15 is iron deficiency. Hematologists only do ferritin. We don't do iron profile. We don't do serum iron. It only causes confusion. Yeah. Thalassemia, how do you diagnose? You do a hemoglobin electrophoresis and the ferritin will be normal or high. So this is one example of how the equipment machine interpreting those values, knowing the genetic background, knowing the profile of the patient, looking at older reports and peripheral smear kind of gives us that right direction. Something similar happens in neutrophils. You see, these are granules. Normally, these granules are not that dark, right? You see this. Let me show you. You see, normally the granules in neutrophils are not very dark. This is normal staining neutrophil. But if you look at the other one, the granules are so prominent. This is what we see in sepsis. This is what we see in infections, because neutrophil is the soldier which is getting ready to go and kill the bacteria. So the granules have the enzymes which will kill the bacteria. So the granules become hyperchromatic. They have more color. Similarly, at the other extreme, there is a bone marrow problem called MDS, where it's not a normal neutrophil. So the granules don't stain; they are faint. They are faint, right? So this is another way. And finally, we have something called as left shift. You see, bone marrow is the factory which makes RBC, WBC platelet. Now, in the factory, you have the initial cell, that is the blast, and then it matures, and then the bone marrow pushes it out in the blood, and in the blood, usually we see neutrophils. But if we are even seeing the immature WBCs in the blood, they're supposed to be in the factory. They're not supposed to be coming out in the blood. Then there is something different. Then pathologists call it left shift. That means you are seeing myeloblast, myelocyte, promyelocyte, all that. So when you are seeing immature cells in the blood, that's called as a left shift. We see this in infections, we see this with certain injections, and we see it in certain leukemia. So again, we need to know that, okay, there is a left shift, but if it's acute, happened in the last 2 weeks, it's probably infection. But if the WBC count has been high and the left shift is going on for a few months, probably a leukemia. Yeah, that's where your profile comes. And then you would also call up your pathologist and say, do the cells look normal? Do they look abnormal? Do they look cancerous? Do you think this could be a myeloid or a lymphoid leukemia? Quite often under the microscope, they may be able to tell you. So this was our first and introductory talk, and I hope you will find this course useful. All the lectures would be uploaded on this YouTube channel, and we will also be sharing the PDF of the PowerPoints for you. Tomorrow we will be uploading the exam. It's going to be a small 10 MCQs after each talk, just to kind of tweak your brain to see, make you think and does remember this. Please try and complete your exam within 2 days, that is by Sunday. So every class will be on alternate Thursdays, and the exam, the MCQ has to be completed by Sunday. That's going to be important for your final certification. You also have my mobile number, and if you have doubts, I would encourage you to write these down. Later on you think of something and ask it during the next class. If it's a burning doubt, just call me, and we will take care of it. Yeah. um, the session is open for questions. I'm going to look at the chat box. Yeah.
Good afternoon, sir.
Good afternoon.
I'm Dr. Nikhil. So I have
Yes.
a doubt with respect to, like, when we take a CBC sample, and in that, when we analyze the report, there will be a place where they will mention MCV.
Hmm.
So will that be accurate, or like based on we should we go based on peripheral smear, sir? Thank you.
No, if the machine is calibrated, that is more accurate than manual peripherals. Again, everything comes to calibration in quality control. And if the lab is managed by a decent pathologist or technician and they're calibrating it, the machine value is more accurate.
Thank you, sir.
Excuse me, sir. I am Dr. Hanifa.
Yeah.
I have one doubt. During this dengue phase, we have seen lots of cases of thrombocytopenia. So we used to be worried, okay, what is the platelet count? So this, as you said, this machine report, it comes very faster, and then it will be followed by, it will be reported by the pathologist. So always, like, we used to get the, we used to hear it from the pathologist, you just wait, machines are not accurate because we will be seeing personally, so that is more accurate. So what should we do?
If the machine is calibrated properly, it is more accurate. As a hematologist, I'm telling you, and it's a good machine. So there are all kinds of machines. There are very cheap cell counters which may not be accurate. If it's a machine from a standard company, your Sysmex, etc., it's far more accurate than even me measuring the platelet count as a hematologist.
Thank you, sir.
Excuse me, sir.
Thanks a lot.
Excuse me,
Yeah.
sir. So
Yes.
sometimes, no, the platelet clumps will be there, no, sir. That time
Yeah.
machine count is good, or
Correct.
it
So
will
in
be
the
like
thrombocytopenia class, we will address the issue of pseudothrombocytopenia. Pseudothrombocytopenia means, I gave you one example, giant platelet syndrome in East India, or there are platelet clumps. When there are platelet clumps or giant platelets, you manual is definitely more accurate than machine.
yeah.
But those are not common. See, anytime there is low platelet count, the pathologist is supposed to make a smear and look at it. When they make a smear, and if that smear does not show platelet counts, if it does not show giant platelets, then the machine is more accurate.
Okay. Okay, sir. Thank you.
Anything else? Yeah, Dr. Suchitra.
Good evening, sir.
Yeah.
Sir, what is your opinion regarding Metzger's index, which is, to differentiate between thalassemia and IDA? Most of the time, it's a very on the fence kind of number. It's either a 13 or a 14. So, and then of course, ferritin levels also, especially if it's post-infection, it's very difficult to say whether it's because of that or because of anything else. And now most of the reports come with this printed on the on the report. So the patient is constantly asking, whether do you think I have thalassemia, because it says this. So
As a hematologist,
watching one
for the
video.
last
Class
20
is there.
years, I have
Where
never
are you?
used Metzger's index.
Where
It
are you?
is it is not used in practice.
Who is
That
there?
was hi, somebody.
Okay.
Yeah, can you please mute yourself?
5
You're
minute
not-
more class is there.
Can you please mute
Hmm.
yourself? I don't know who's talking. Okay. So Metzger's index was used at a point when, as a screening tool for population. So you want to screen one tribal area, and there's no way you can afford HB electrophoresis for 1 lakh people. So at that point, you do a cell counter CBC and then calculate Metzger's and then screen people who need HB electrophoresis. Okay. So it was used as a screening tool. But today we don't do that. You do a ferritin. If ferritin is low, give iron. If ferritin is false high due to infection, and you still suspect iron deficiency, give iron and repeat ferritin after 4 weeks. Because if ferritin has gone up as an acute phase reactant, it is going to come down in 4 weeks. 1 month. 1 month is a fantastic time point, At the same time, if ferritin is normal and you want to rule out thalassemia, send HB electrophoresis. Using Metzger's index, and these are outdated things. They are only going to confuse you and delay the right diagnosis. It is better to go ahead and do the right tests. My professor in CMC Bangalore, one day he got irritated with me when I was having this kind of a discussion with him. And he said, you don't have to be Sherlock Holmes in practice. Just do the test and find out if the disease is there or not.
thank you, sir.
Yeah, you're welcome.